So there's a few features of this report I want to highlight before I get into specific grades and specific features. And the first is, after the table of contents, is this infographic right here. We found this graphic has been very powerful with state lawmakers. It is sort of a quick breakdown of important numbers that are needed to be known for medical cannabis patients and medical cannabis legislation. So the first one I want to highlight is, as of June 1st, we have counted all of the patient registry card information that's available publicly, and estimate that there's over 3 million patients now in the United States. For perspective, 1.9 million of those patients are not in California or Maryland. Those two states don't require a patient ID registry card. When we put together this data, it is never something that has personally identifiable information or really anything more than the number of patients and the types of conditions that they have. So we always make sure that when these reports are collected, that patient privacy is protected and it's compliant with HIPAA laws and other various healthcare privacy provisions. The next important number is the comparison on this page and the following page of prescription drug deaths versus the deaths caused by cannabis. Up here at the top of this page, you can see that 0 deaths have ever been reported to be caused by cannabis. Meanwhile, in 2017, the most recent year that data was available, we had over 70,000 deaths from prescription drugs. Other important numbers on this page are both the years total of clinical trial data related to the use of medical cannabis. Were over 9,000 collective years, and then across all 50 states, there have been over 95 distinct and discrete medical conditions approved by healthcare practitioners for the use of cannabis. On the next page, we have some polling data about the current level of support across the country. Recent polling shows consistently above 90%. This 93% is from a Quinnipiac poll showing that medical cannabis has a tremendous amount of support compared to some other political issues, and frequently is more popular than several lawmakers themselves. So moving past this graphic, we have an introduction about how this report came into fruition, sort of the pathway of how industry has developed since our citizen-run initiatives in California and some other states in the mid-90s, and an explanation of how we have begun to evaluate and continue to evaluate state medical cannabis programs. We also highlight in this introduction the campaign that we launched in 2017 called End Pain Not Lives. This campaign looked at how states were using their medical cannabis programs to impact and to reduce preventable deaths caused by the opioid crisis. So in last year's report, we previewed that there was going to be a new scoring category compared to years past. In years past, we had given states a somewhat subjective improvement bonus of up to 35 points, but have switched this category to something that's more concrete, and it's the opioid response category. So this rubric right here is a new assessment for the State of the States report. We looked at several different categories, particularly related to pain patients, pain research, and affordability. We found from patient feedback that these were the most important categories to assess. So we wanted to make sure that this was included in our scoring rubric as we were moving forward. We also included a update to our qualifying conditions list. As I mentioned earlier, there's now over 95 conditions that are distinct across the United States for the use of medical cannabis. However, the most popular condition across all states and across all territories continues to remain chronic pain. As you can see from this chart, nearly 2/3 of our respondents and of the condition list that we were able to review reported using medical cannabis for chronic pain. Many of these chronic pain patients also reported using cannabis for another qualifying condition, but this pie chart very dramatically shows the breakdown of patient conditions that are most popular. We did the 10 most popular right here in this condition chart. We've included a condition tracker on our website that we are keeping regularly up to date. That is something I will pull up in 1 second. Is the condition-based tracker that we have updated. It is now a Excel file that I have to sign in for. So, but the point being is that we will keep this regularly updated as states add new conditions to this qualifying condition list. The next key feature of this report that has been consistent from years past is this timeline. We show the evolution of the number of states with medical cannabis programs, the number of patients, and as new states come online, and as well as something that's been fortunately significantly decreasing over the last few years is the number of federal raids that have been reported to us by dispensaries or other facilities. So looking at the map for 2019, we only have 3 states, Nebraska, South Dakota, and Idaho, that are completely without any form of change in law to the Federal Controlled Substances Act. There is an initiative that has already been certified in Idaho, and Nebraska is close to being certified for both of them having medical cannabis on the ballot in 2020. So hopefully those initiatives will go well, and if you know anyone in those states, please work with them to get as many signatures as possible so we can have this map next year be entirely filled in. Moving on, we have a overview of cannabis science. We have several more reports on our website at Americans for Safe Access that go deeper into research and things like terpenes and different cannabinoids. But for an introductory measure for a lawmaker, these 2 pages really quickly and effectively show some of the different chemical and scientific components of the cannabis plant. Next, in the scoring is our individual breakdown of what specific categories mean before we get to the rubrics. So we go through each of our 5 major categories and we show a brief description as to how we assess and how we evaluate access and programs. Some of these categories are a simple yes or no. They get full points or not full points. Some are a little bit more nuanced, where we have to give partial points based on an interpretation of how a state has adopted either our model language or something that is close to our model language. And that's where we usually get partial points in these categories, or partial points in these categories, or fractional points. So it is something that, although we do have this large matrix, we do sometimes still have to compare states to other states that use our model language or that use language that is very patient forward, and that sometimes results in the splitting of hairs. But it is an important distinction to have all of these categories be present. So the first category is patient and civil rights, and we're really looking here to making sure that state programs and state court decisions are not overtly discriminating against medical cannabis patients. we have found that while legislatures are sometimes effective about these protections, including the protections such as medical cannabis patients can't be terminated from their employment. There's a caveat with that because unfortunately right now no state in the country prevents a private employer for terminating a medical cannabis patient when that employer deems them to be impaired. However, states have prevented employers from terminating or from failing to hire medical cannabis patients solely because they are cardholders. So this is something that we see shake out a lot more in the courts rather than in the legislature. It becomes the interpretation of adverse events, and sometimes courts have to decide what actually constitutes an adverse event or an adverse action by an employer. We also look at things like reciprocity in the state. Reciprocity can cover a lot of issues, whether a patient's card is valid for the possession or purchase limits in that state, or something more nuanced if the patient is allowed to fully access all the dispensaries and the other benefits of being a patient in the state where they're not necessarily a resident. So the next major category is assessed on access to medicine, and this is largely based on what's actually in the laws and in the regulations. We certainly hear all the time from patients that just because a state has an adequate number of dispensaries doesn't necessarily mean that the dispensaries are serving them appropriately or there's enough access points. We look at things like sales tax in this category. It's ACE's position that all medical cannabis should be tax-free. However, the political realities in some states prevent that from happening. And in the states that those are prevented from happening, we look to see if cannabis is taxed at a rate comparable to over-the-counter medications or herbal supplements. Usually, and again, this is depending on the state, it's in that 5 to 8% range. But again, we'd love to see cannabis be tax-free, but that is something that we are working on and are having, I think, a lot of success with, especially as states move towards adult use legalization. We're able to ensure that patients have tax breaks protected into these frameworks as they come online. And I won't go through each one of these categories. I just wanted to highlight a few important ones. We also assess local bans and zoning in this category. We look to see if municipalities can actively prevent medical cannabis businesses from being active in their area. We've had this problem in California for several years, is with localities banning storefronts and restricting patient access. So we make sure that if a city or municipality is going to have a zoning regulation, all are going to have a zoning regulation that is fair and it is zoned the same way that perhaps a pharmacy would be, or something that's not overly restrictive. The next category that we review is ease of navigation. This is something where we certainly take in patient feedback. It's something that's not necessarily immediately available just from looking at the laws and regulations. So we, as part of this report, issued a patient feedback survey. We received over 500 responses all across the country that dealt with things like affordability, whether it was easy for minor patients to access the program, whether caregivers were facing undue scrutiny, the ease of adding conditions through either the state's petition process or through the Department of Health, And then some more, again, concrete things like multi-year registrations for caregivers and for patients. But this is a very important category. And as we issue this report each year and we get feedback, this category continues to evolve. And as we get feedback from this report, we'll be looking at the grades that we gave states and making sure that they are still an accurate reflection of what's going on in the state's program. The next major category is functionality. And again, this is something that is a blend of both the laws and regulations and the patient feedback that we get. Typically, with the CBD-only states, particularly in the Southeast, this access to medicine category that is first on this page, you usually don't see a state getting more than 5 or 10 points in states that don't have distribution systems or allow home cultivation. In the states that do allow both those in terms of dispensaries and home cultivation, you see this point range become much higher, usually above 35 and then all the way up to 50. I wanted to highlight the legal protections within a reasonable time. We are working on making sure that medical cannabis patients can access their medicine the same day they get a recommendation. A few states have adopted this model where as soon as you receive your confirmation email for submitting your application to the program, you get a temporary card. Once that temporary card expires, you don't have any gap in medicine because of the way the laws are written, basically saying that you can immediately go into the dispensary of your choice and use that confirmation email and your recommendation from your healthcare provider as proof that you are registered for the program. Something that every state struggles with is whether or not cannabis is covered by insurance or state health programs. No state can make a claim to the full points in this section. We are constantly working with state regulators and state insurance bureaus to work to provide coverage for medical cannabis. Some states, like New York, cover the initial visit where you can get your recommendation, but they won't cover anything beyond that. So we really constantly hear that affordability is a big issue for patients, and we couldn't agree more. So we really like to focus having states making the programs more accessible and medicine more affordable. And the final major category that we assess state programs on are their regulations for product safety. And so these break down into different facilities, their regulations for dispensaries, their regulations for cultivation and manufacturing facilities, and then ultimately laboratory testing for products and then for flower as well. So we look to make sure that cannabis employees at businesses are well trained and they are engaging in standards that are going to ensure safe medicine for all of the consumers and patients that they serve. So we really look at things like how they are dealing with storage protocols, what pesticides they're looking at, whether they're using an inventory tracking system, if they've set up a good and adequate recall provision. So this is something that is going to be almost entirely from the regulations of a state. These are areas that lawmakers in legislation infrequently deal with themselves. And we really want to make sure that when we're interfacing with lawmakers that we also are having these conversations with regulators who can implement good product safety regulations. Another favorite of this report is this distribution and regulatory oversight graphic. We have shown this to several lawmakers and several regulators, and it really clears up the process of what they need to be doing when they're implementing a medical cannabis law, or how they can improve their existing medical cannabis supply chain. I know we've had some issues in states like Utah and for a while Louisiana in terms of a state-run supply chain. This graphic really sort of shows how that is less than feasible in the current market. So it's a great resource to use to understand cannabis from the ground all the way to the patient's hands as the final consumer. So now I will get into the state report cards. And again, I will not highlight every single grade, but I do want to give everyone a good overview. This page shows our overview map of laws and regulations passed in between January 1st of 2018 and June 1st of 2019. So between that period, about 2,200 laws were put forward by state legislators. Of those 2,200, approximately 400 passed. So there was certainly a lot of information to incorporate in this report. A major trend of this map is that every state with a CBD-only program received a failing grade. Then that includes low THC programs and THCA programs like Virginia and Georgia. And that's largely because the availability of diverse products and the level of patients that these states can serve do not effectively serve a larger population like some of the states on the West Coast and in the Northeast do. Something else that's notable about this map is that for the first year, we were able to give out 2 grades in the A range. The first is in Illinois, and the second is in Oregon. And the Illinois grade resulted from a bill in that state that allowed anyone with an opioid prescription to trade in that opioid prescription for a medical cannabis card. And then, as many of you know, Illinois passed an adult use legalization bill, but they were very protective of the patient rights in that bill. The patient rights in that bill, they allowed home cultivation for patients and eliminated any tax rate. And then Oregon is the other grade in the A range, and they finally fixed some product safety and product testing issues, and were able to bump up through the regulatory process. So I will let everyone just sort of take a glance at what our report cards look like. I'm sure everyone on here is looking at their specific state and how their state did. And I am happy to answer questions about state-specific issues rather than the report at large, either outside of this webinar or in the Q&A to the best of my ability. But for those of you who don't have it, my email is david@safeaccessnow.org. So if there is something that is very problematic or something that you are excited about in your state-specific report card, I would be happy to hear the feedback. The patient feedback is something that is very critical in making this report, and I'm happy to issue corrections for the online version as we need to before October, when bills are going to be pre-filed around the country. So I'm going to skip down to the conclusion. Oh, I did also want to highlight West Virginia before I get to the conclusion. West Virginia passed a comprehensive cannabis bill, medical cannabis bill, in 2017. However, they were supposed to have product ready for sale by July 1st of this year. A regulator in their Department of Health said that deadline was going to be nowhere near being accomplished, and it could take another 3 to 5 years before their program is up and running. So we want to highlight West Virginia to show that even if your state is sort of moving forward legislatively, if they're failing to do progress on the implementation side and the regulation side, it's very possible that the grade will go down. But we look at the improvements and the tractions as a whole and sort of make that assessment with our rubric and our patient feedback. But certainly hope that West Virginia has a timeline that is quicker than a 3 to 5 year period. Patients in that state certainly need to have access to medicine and stop being delayed. So in the conclusion, we overview some of the trends I just talked about. This map right here is a map of patient concentrations for the CBD states. Many of these states didn't have an accurate record or had a patient population of less than 600 in their registry. For states like Missouri and Utah, West Virginia, these states haven't started issuing cards yet, so we don't have an accurate count from those states. But as you can see, the heaviest concentration remains in California. They have the longest program, and then closely followed in terms of concentration per capita by Michigan, Florida, and then a few states in the Northeast. So we will continue to update this map as we get periodic updates from departments of health on number of patient population, and we'll continue to have that active on our website. So as an overview and a different display of the information in terms of how the grade distribution went this year, again, it was a very positive upward trend for medical cannabis programs. We had 2 A-minuses, 7 B+s, 9 Bs, 2 B-minuses, 2 C+, 5 C+, 5 Cs, 3 C-minuses, 1 D+, 2 Ds, 1 D-, and 17 failing programs. Again, most of which are the CBD-only programs, but that also includes West Virginia. This table on the following page gives an overview of grade changes from year to year, where programs have fluctuated up and down. And again, for the most part, the trend has been one of upward improvement. So that is certainly something that is positive. Here is where a lot of you all come in, is ASA's role in shaping legislation. A lot of our chapter advocates and regional leaders have been instrumental in pushing some of these reforms on this page forward. So we thank you for all your hard work in that regard, and didn't want to necessarily name any of you by name for privacy reasons, but if you are from the states that are listed here, we certainly recognize your efforts and certainly appreciate what you've done to move forward access to medical cannabis. So the next new feature of this report is this section. We've included several features that each state can adopt that doesn't exist yet on a large scale for their medical cannabis program or lack thereof. And so these are sort of viewed as universal improvements, that something that every state in the country, if they did at least 3 out of 5 of these, it would significantly improve their grade. So the first, like I mentioned a little bit earlier, insurance coverage, making sure that medical cannabis is affordable, so patients aren't paying entirely out of pocket for medication. The next is letting healthcare practitioners decide. We have this in a few jurisdictions, Massachusetts, Maine, Maryland, DC, California, and Virginia. So what this provision is basically that it prevents lawmakers from listing a limiting list of qualifying conditions due to how some of these programs are structured. Legislators still want a list of qualifying conditions, but we add on letter G here, which says that a medical provider can recommend cannabis for any condition that they determine will be benefited by cannabis. The next universal improvement is what I talked about in Illinois, the opioid prescription trade-in. This allows patients who have been prescribed opioids for any reason, including acute pain, to trade in that prescription for a medical cannabis card and immediately begin participating in the program. New York's Department of Health has adopted this. Colorado has adopted a version of this spring, thanks to our advocates there. But this is certainly something that would help mitigate the opioid crisis and allow for a wider population of pain patients turning to medical cannabis first, rather than having to turn to dangerous opioids. The next provision is making sure that delivery is available, particularly in states that are limiting the number of licenses that are issued to dispensaries. We put in this delivery language to make sure that all patients in a state could access the program and access what is available in terms of medical cannabis. And the last one of the last universal improvements is ensuring civil rights protections. Well, though I said there's been a number of court cases that have dealt with these issues, we also have model language that ensures that there are protections for child custody, for housing, for organ transplants, for roadside testing, and then for some states, it's important to include possession of a firearm shouldn't be prohibited as your status of a patient, so we have language for that as well. The final improvement is making sure that regulators provide adequate cannabis education for healthcare providers as well as for medical cannabis business staff. So we, as many of you know, have our PFC program and our CCC program, which work to provide patient and then employee education to making sure that the medicine coming out of these facilities is as safe and as helpful as it can be. So our last appendix in this report is our recommendation to regulators. This expands a little bit more on our PFC program and our PFC standards, and urges regulators to work with us and some accreditation bodies like the American Association for Laboratory Accreditation to make sure that everything that's coming out of their state has gone through good manufacturing practices and several other categories. So last, although this is a state report, we are always active on the federal level. I know many of you joined us for our lobby day during Unity Conference, where we talked about the Office of Medical Cannabis legislation. What this section is a resolution for state lawmakers urging that sort of oversight. We don't include the full legislation that we did in our congressional briefing book here, but it is something that a state lawmaker can pass that urges the federal government to have a framework like the one we established with the Office of Medical Cannabis. So I'm going to turn to questions and comments now, and like I said, we'll answer them to the best of my ability, and if I cannot, I will get back in touch with you afterwards, and we will get the questions answered. Hey, Jeff.
Could you clarify if the 70,000 number, is that due to all prescription drug deaths, or are those ones that would just be something that you can place with medical cannabis?
The prescription drug death number is all prescription drugs, but the significant majority of those comes from fentanyl as well as oxycodone. So I think it's about 70% of that 70,000 are medications that are easily or could easily be replaced with medical cannabis. There's also a number of prescription drugs in that category that are used for mental health disorders, including PTSD. So while it's not all prescription drugs that can be replaced, by that number, it's certainly a high percentage, but I don't know the exact number, but I can get back to whoever had that question.
Can you also speak to the sort of how programs that have medical programs and adopt adult use programs, how they can factor in patients and keep patients focused in that?
Sure. Yeah, we've seen a couple of different models happen when states move to adopt adult use. And the first I want to highlight is what not to do. Washington State adopted an adult use framework, and they were really careless in terms of what they were looking at for protecting the patient rights and patient program. They ended up collapsing their market, which basically means that the adult use dispensaries and the medical dispensaries were serving the same population. They ran into a lot of problems with shortage and product supply. They ran into problems with only having high THC products on the shelves, a lack of extracts. So what Washington did, they thought they were going to have one supply chain, but it ended up severely hurting the patient population in that state. The state's now just recovering almost 4 years later from some of those decisions. They still have a lot of improvements to go to fully, I think, return to the positive status they had prior to adult use legalization. Another model is similar to what California did. When California passed Prop 64, they greatly increased their testing regulations and their product safety regulations across the board. So, prior to Prop 64, testing in California was often subject to the individual discretion of the dispensary or of the retail facility, and Prop 64 required all businesses to test in the same way, and it greatly increased the standards for the medical program. Illinois, like I mentioned, they passed a adult use legalization bill, but they were very careful to ensure that patient protections remained in place. They limit home cultivation only to patients, allow patients to have first access, allow separate, require separate retail storefronts for medical and adult use, and have done a adequate job, at least so far. We will see with the implementation of keeping patients first and making sure that the patients in that state are protected. So when an adult use state comes online, it's just important to remind these lawmakers that there are very important patient rights that need to be protected, and states can do it in a way that improves outcomes for patients, but they can also do it in a way that harms patients. So it's really just making sure that as a patient, you're part of that conversation. If you believe that your state is moving in that direction, states will often have public comment periods and listening sessions. So we are happy to help prepare anything for that in that regard, just making sure that the categories we mentioned in this report continue to be well served before a state considers adult use legalization.
Could you also speak to how we can encourage or develop reciprocity, allowing medical patients to travel more freely?
Sure. What the District of Columbia just did, I think, is a good example. DC just opened up their program to anyone who has a card from another jurisdiction can come to DC and choose any of the dispensaries in the city. And as a visiting patient, there's no additional hoops that anyone has to jump through, like registering for a temporary card when they travel or anything of that nature. So as more states consider the question of reciprocity. It's important to, one, make sure that possession limits and purchase limits are honored. There shouldn't be any restrictions for someone out of state who is coming into a medical dispensary compared on their state of residence. And the other thing is to make sure that the card from another state gives you the full rights of a patient within that state. Arizona right now currently doesn't allow individuals from out of state to go into dispensaries. It only allows them the affirmative defense protections. So making sure that those protections are very much in place, and then making sure that patients know the rules of the road, metaphorically, in the states that they're traveling to. We don't like to have surprises. We are going to be issuing a travel guide later this fall that deals specifically with reciprocity and moving from one state to another. So please stay tuned for that.
David, could you give some sort of maybe just a brief touch on how patients can use the login tool?
Absolutely. So we don't want any grade in this report to indicate that work is done in a state. So if you are talking to a lawmaker, either on the federal or the state level, especially the state level, show them that their grade is not an A+, that there is always progress to be made. If they're doing well, certainly congratulate them on the progress they've made so far. Sometimes lawmakers like to be thanked, not just jeered at, and then you can use that thanks as a way to leverage a further conversation about what needs to be improved. So certainly bring this report, or print out the one page of your grade and bring that into a meeting, or send them the link. And it really can be used as a conversation tool to say, here's where our program has been, here's where our program is, here's where our program should go to effectively serve the most number of patients.
Okay. We also had a question about treating cannabis as agricultural. Not really.
So under the 2018 Farm Bill, quote unquote industrial hemp, which is cannabis with less than 0.3% THC, is considered an agricultural commodity. Cannabis plant with a greater THC content than that, I think some states might be considering it an agricultural commodity, but that's not really something that we've looked into beyond the Farm Bill. I do see a couple of questions about Virginia. I would like to talk to you offline, Deb, about what Virginia has done. I think there's a lot of different interpretations, ours included, of what actually happened in that state legislative session, and I want to make sure that we're conveying accurate information before I address the whole crowd. So thank you for bringing that to my attention.
Okay. I know we want time for Debbie to close out, but if you have, or we hand it over to her.
No, I just we have a blog called the 5 Major Takeaways on our website. We have an action alert set up on our website, which are both going to be dropped in the chat to share this with your lawmakers. And I do just want to stress, is like, this report is a living and breathing document. There's already parts of it that are unfortunately out of date by the time we published it. Policy in the cannabis world moves incredibly quickly. We have to set a cutoff time for the publishing of this report, but we are certainly always open to revisions and changes and specific targeted actions in states. If you need our assistance in explaining a grade, or showing why a grade is not the grade that they actually originally deserved, we are happy to work with you. and assess and see if it's consistent with what we're hearing with other patient feedback. But yeah, please just review this report, use this report, and make sure that you use us as a resource here in DC. A lot of times we look at what's happening in a state from a 30,000-foot view. We might miss some nuances and intricacies of the state's program that's serving you as a patient on the ground. So we appreciate your attendance for this webinar and appreciate the feedback, and I will turn it over to Debbie.
I just wanted to give a big thank you to David, who was the main author of this report and who literally created the world's longest Excel of state grades and categories and everything. It's crazy to look at how much went into this report. And we really do appreciate patient feedback. So, but we want to make sure that we are utilizing your feedback the best way possible. So please make sure if you do provide feedback that you kind of highlight what category or issue that you think may have deserved a different score. I also wanted to, let me see if I can share my screen. I'm going to share my screen real quick. All right, okay. I wanted to show this again. Sorry if David already pointed this out, but something new we did this year was we color-coded the states by blue being full medical cannabis program, yellow being states that only had CBD or very, very low THC levels. Green are states that have medical and adult use, and then gray is the states that don't have anything. And I think this is just a really great map for people to use. Please feel free to use it, cite us, but I think it's a great representation of the country. As David mentioned, the report, we finished writing it in June, so there has been a few changes, which we are aware of, but as the system is medical cannabis and cannabis is just moving so quickly, things change so quickly. So we will be sending out a survey as we did last year for next year's report. So make sure you keep an eye out for that so that we can hear your feedback and include it in next year's report as well. Thank you for your questions and for listening. And I wanted to announce for the first time also that we actually have a date for Unity 2020, believe it or not. Our National Medical Cannabis Unity Conference will be March 25th through the 28th. So please mark your calendars. It's such a great conference. We try to have people come from all over the country. We'll let you know when the scholarship program is up, but Unity 2020, March 25th through 28th. Once again, thanks everyone for joining, and we'll see you next time.